with cannabis, the mantras are start low, go slow, and then I added this one and deliver where it needs to go. So it's actually most important in three, in my opinion, because we often think of cannabis more like smoke and take it orally, forgetting that there's all these other applications. I'm actually working now with a very cool group on trying to figure out how can you put cannabis in the eye, because for glaucoma, people smoke currently. That's not a really good intake because it doesn't last very long and can have a lot of side effects. And really the main reason, if you put something directly where it needs to go, amount of what you need to put there is way less. And so you're avoiding systemic toxicity, you're cutting the cost, you're making it logistically a lot easier, because often, and you're literally often removing any serious functioning problem, because one of the big practical reasons why a lot of people don't want to use cannabis, they're afraid of getting high. Let's put it this way. If you have pain and you smoke pot and you get high, people say, well, my pain is better, but I'm high. I don't want to be high. So what do I do here? Well, if you have a pain in your feet, for example, a neuropathic pain, we'll try topical first. And I'd say that in some percent of people, it works, and it works really well. And they don't have to smoke or take anything orally. And suddenly you have a tool that is highly effective, relatively low cost, and zero central or kind of overall toxicity. I mean, you can have theoretical toxicity there, but it's way, way less likely to happen than when you take things orally or when you inhale them.
Today we are happy to discuss medical marijuana. This is one of our hot topics of today. Medical marijuana has been in use for the last few decades, and even before that, as an alternative to help with anxiety, pain, inflammation, sleeping issues, and much more. Nevertheless, it can be confusing and even controversial to understand how and when to use it. Today's guest, Dr. Mikhail Kogan, is here to help us demystify medical marijuana and discuss its origins and therapeutic uses. Dr. Kogan is Medical Director of the George Washington Center for Integrative Medicine, an Associate Director of the Geriatrics Fellowship Program there at GW, and is Associate Director of the newly formed GW Interdisciplinary Integrative Medicine Fellowship. He also recently published an amazing book, Medical Marijuana, Dr. Kogan's Evidence-Based Guide to the Health Benefits of Cannabis and CBD. I am Dr. Andrew Wong, co-founder of Capital Integrative Health. This is a podcast dedicated to transforming the consciousness around what it means to be healthy and understanding the root causes of both disease and wellness. Don't miss this discussion with Dr. Kogan about the benefits of medical marijuana, or rather we should say medical cannabis, and what you need to know before using it. Well, thank you, Dr. Kogan. Thank you, Misha, for coming on today. Great to have you on. Thank you so much for taking the time.
Thanks, Andy, for having me.
Yeah, so Misha's been a good friend and mentor for a long time now in integrative medicine. Certainly one of the aspects that, Misha, you're an expert on is medical cannabis. And I know you recently published a book called Medical Marijuana, Dr. Kogan's Evidence-Based Guide to the Health Benefits of Cannabis and CBD. Let's kind of start with the basics. I think I learned this from the conference that you hosted at the GW, the IM4S conference, and I think you had Beth there. You were talking about how basically this idea of cannabis as a one of the originating from one of the original crops that we have cultivated in the agricultural times to becoming essentially maybe demonized or something, or having this idea of this is not a good substance or something. So let's just first talk about what is cannabis and marijuana, and what's the difference there, and just kind of get into that real basic first.
Right. It's interesting you brought up like the history here, because this is one thing that history comes in full circles, right? I mean, before the prohibition, the cannabis was kind of everywhere. It was the part of the treatment plan for so many different issues, including it was actually part of a pharmacopoeia in US, which is a standard prescription guide for something like a century. And before that, it was one of the oldest medicinal plants that was used for a variety of different reasons, and not just internally. Externally, it was used a lot as well. Ritually, it was used a lot. So it was pretty common, and no one ever looked at this as something controversial. I feel like it always been with the humans for thousands of years, simply as part of our not just medical, but a lot of daily routines for a variety of reasons. And, so we are now rediscovering this. Of course, we're rediscovering the molecular structures. So we're rediscovering how the plant interacts with our own and the cannabinoid system, which turns out we have. And so I think this whole conversation should sort of be circling around this particular topic, where turns out we have our own cannabis system inside of us, and it's extremely profoundly complex. And it is much older than endorphin system. It seems to be much more important for regulation of not just the brain activity and things like pain, for example, or perception, but also immune system and bone development, muscle development, and heart function. And pretty much almost anywhere you look, with very few exceptions, the cannabinoids have some kind of regulatory or direct impact on particular function of our physiology. And so, with that in mind, here you have a plant that we now call marijuana, or for past whatever decades before, of course, it was just called cannabis in different languages, different words. And now we have these terms as hemp, CBD, and a lot of terms that are very new, right? So the term marijuana, which is basically describes cannabis, one would argue, though, that the cannabis is a botanical term and marijuana is more legal term or recreational term, if you will. But there's a lot of problems with that nomenclature to begin with. I'm just going to use it today interchangeably because I feel like marijuana is more of a historic word now that doesn't describe anything botanically or medically relevant. It's just there because the whole cultures grew up on this, because there's a huge political attachment to it. And actually, I feel there was a lot of discussion in our smaller circles of the experts in this field who feel like this word should be removed from dictionary because it's in a way made up word, only had negative connotation when they made up the word. It became popular in a culture and we're still using it, so let's get rid of it so that we go back to cannabis and just keep it strictly medical in terms of the word. The problem with that is then what do you do with the whole history here? Because unfortunately history here is not very good. There's a lot of racial disparities, there's a lot of segregation based on the word. And so I think it's essential to keep the word more as a history and say, look, we got this one totally wrong. We had a government telling us total BS for decades, claiming that this is dangerous substance with no medical use. And it turns out not only they were wrong, but they were just simply using all of this for political reasons. And now we know the history that starting with Aslinger, going back to the 1930s, where they needed a scapegoat money to establish DEA office, in essence. And they got this money and they're still operating on that budget decades later. And the entire industry here, quote unquote, was established with a lie. I think it's worth for the public and for everybody to know that. And so I feel let's keep the term. So let's go to the CBD term and hemp term and THC, which are sort of the highest used words in our cannabis vocabulary. So the hemp is literally, usually we mean it's an industrial product that has less than 0.3% THC, and then its application is not for medical use, but just for industrial use, for the textile, for the protein, for the food. For now, the most fascinating thing with that I've seen is there's a hempcrete, and apparently it's one of the most fastest growing industries in the construction industry in the world. Apparently it's stronger than a regular concrete, it's fireproof, there's all kinds of benefits of having hempcrete. It's also rapidly generatable and renewable, and I have no idea, don't ask me, that's not my area of expertise, but I just went to the conference where this was discussed heavily. So the hemp is industrial. The CBD from hemp is now sitting in that agriculture bill. So which is not even the CBD from hemp is now not even considered supplement. So by the way, those listeners who are wondering sort of why the CBD has a totally separate purchasing process and you can't even buy it in a regular supplement stores like large respected distributors like Wellawait or Fullscript, that's the reason, because the supplements are regulated by FDA and CBD is not. CBD is under agriculture bill. It's not even considered food. It is sitting under a completely separate like domain, similarly to some degree to cosmetics. So it's a very interesting legality here that puts it in a weird category. So CBD from hemp is there. And then we traditionally used the word non-psychoactive. Now we don't use that. We say psychotoxic. So psychoactive is much broader word. Psychotoxic means, something that makes you euphoric. So CBD is not going to make you euphoric, no matter how much you take. It's the THC that will, right? And THC is pretty much the only ingredient in cannabis that it will. I know it was a long answer.
No, that's very comprehensive. Great overview to start with. So it sounds like there's medicinal uses for cannabis or marijuana, depending on how we say that. What are the conditions that either medical cannabis or CBD are most helpful for in your experience?
Right, and I'll put the plug for the book here because the book has intro and some orientation chapters, but then you have a lot of medical chapters. And what we try to do with the book, we try to say, look, what are the most common and most evidence applications of cannabis, and let's group them in categories and center chapters around those categories. So there's a significant symptom support, and I will divide those symptoms into several categories. So pain is a huge one. And this is where both THC and CBD has a role to play. THC probably has a bigger role than CBD, but there's a lot of lack of clarity as to what is the best mixes, what are the best combination, what are the best kind of doses, ratios, routes of administration for specific types of pain. But in generally, I would say cannabis should be somewhere between the first and second line of treatment for any chronic pain. Now, I'm not going to be afraid to say that in public, in open. And it's not just based on 2017 National Academies of Science conclusive report that says evidence for cannabis for chronic pain is grade A. And we have not a single drug for any chronic pain that is considered grade A evidence. We have grade B, we have grade C, we even have grade D drugs. And for the listeners, if you don't know what I'm talking about, so there's in evidence-based medicine, there's a gradation of the quality and level of evidence. And so there is, when somebody say grade A, it usually means gold standard treatment. So if I were to tell you that for a particular disease, there is a grade A treatment, you will assume that it's a first line gold standard recommended by every agency and every standard or every organization in the country. To give you an example, it would be statins for coronary artery disease. This would be a grade A recommendation. For existing cardiac disease, the statins would be recommended with grade A evidence supported. For chronic pain, opioids are grade C, and grade C means borderline evidence. Never use first line, never use second line, maybe third line use. So in the cannabis, NAS put into grade A, just so that every listener understand. Now, this isn't an independent organization. It's not a government organization, but it's not an industry either. So, and this was a summary of 60,000 articles. So it's a massive assessment, massive review by kind of top leaders in the country. So, I still use that as a big kind of the number one evidenced chronic pain. You have a lot of applications around the cancer, which are also often grade A or maybe B. So nausea and vomiting, pain, as I mentioned, but even things like weight loss and appetite and general well-being. So we do think that cannabis taken for cancer patients not only gonna decrease nausea and improve their symptoms, but they're gonna feel overall better. And especially those who are in the last 6 months of life. So there's a very critical palliative use of cannabis. And that's one aspect that I always intrigued me the most, because we knew this for thousands of years. There is a historic documentation of cannabis used for people at end of life, dating many thousand years ago, not just to Chinese medicine, but to all over the world. In Siberia, the discovery of Siberian princess, the mummy in the ice, that had breast cancer and had a large pile of cannabis right next to her in the frozen ice. So in every parts of the world where cannabis existed as, plant growing out there, people figured out that it was to be used for that. So that's another big category. Of course, there's a whole discussion of, does the cannabis cure the cancer? I'm actually so happen to present today, later in the day, journal club on an article that's actually saying slow the horses. There's some evidence beginning to appear that maybe cannabis is not good for every cancer patient. For some, it may actually do reverse of good. I would say this is a very unclear topic, and part of it is simply we do not have enough quality data. We have a lot of patient stories, so I expect that we're going to see an explosion of more cases. My personal opinion of cannabis for cancer is mixed. I think we're going to see some cancers where it's going to take its own proper disease modifying place, and it's already sort of does in some of our clinics, but the evidence is very weak. The only evidence we have a little bit for curing cancer or supporting cure of cancer is brain cancers. Everything else is, the evidence is non-existent whatsoever. At least in brain cancer, we have a small study, randomized study, showing that the 1-to-1 mix of THC and CBD actually prolongs life. Now that's one study in like less than 20 patients. I mean, we don't typically use evidence like this to make any conclusions, right?
Right.
So that's that. I think anxiety, sleep, like the depression, psychological symptoms can be very effectively managed with cannabinoids. It gets a little complicated there. Interestingly, THC at low doses can be extremely anti-anxiety and very effective for chronic sleep. However, at high doses, THC actually could be anxiety and panic attack provoking and actually blocking sleep. So you got not a simple relationship. CBD seems to be good for a lot of psychological issues, anxiety. There's even some data on in schizophrenia, you can decrease side effects of medications, balance patients with CBD. So there's a lot of data that suggestive of certain things without being conclusive. Definitely a lot of people use CBD for anxiety, and I've seen this being quite effective. The problem is that you have to use a lot and it becomes reasonably expensive if you're using it for that.
I have a follow-up question about that.
Yeah.
CBD can be metabolized by the hepatic enzymes, the P450 system.
Exactly.
If someone has anxiety, depression, and they're on, let's say, a SSRI or other medication, or they have some other, psychoactive medication, how does CBD interact with that? And is it better to, check with pharmacy and all the drug herb interactions there?
You must be preparing yourself to take a certificate and being a cannabis
clinician. I've got to work on that. I've learned from the best. Yeah.
We were just writing a question about this yesterday. Okay. So that's exactly right. So CBD in theory it's a competitive inhibitor of P450. So in principle, you can see a blocking of metabolism of some medications and increase in side effects of certain things. And so there's definitely a concern and warning about it. The funny thing is that we're just not seeing this in practice. Those of us who actually make recommendations, of course, are very careful. I have this weird idea, which I don't know where I got it from, that keep everybody under 100 milligrams a day when you're just managing symptoms of CBD. It's not based on anything, just FYI. It's just sort of my experience has been. But I've heard stories that people take over 1,000 milligrams a day and we're not seeing anything. So are we not seeing anything because those are tend to be younger and healthier people who take this massive doses and it's just time and we will see something? Or is it maybe that it's possible that those interactions are not clinically relevant? And some of the experts, like foremost experts in this field, like Ethan Russo, believe that they're not clinically relevant. I don't want to quote him here, but I've heard him say this multiple times in different settings, making me believe that it's true. I think I've seen one or two things, and even I put a couple of things in the book. I mean, there was a case when I remember early on when patient was taking high dose oxycodone, which is a narcotic. It's a pain medication like morphine, and the person was recommended by somebody to take massive doses of CBD several times a day, and it felt like that person was overdosing on oxycodone. Was it real? Was there other things involved? I'll never know, but the caution is there, I would say.
Okay, so let's go down our first rabbit hole here. Some sub questions based on your amazing answers. So if we know that the 2017 NAS papers recommended grade A, that cannabis used for chronic pain, why isn't it that more available versus opioids at grade C?
Well, yeah. So this is not a rabbit hole. I think it's I think that future generations will look at this and say, there is so much criminal intent in the pharmaceutical industry that's been happening, and we're going to look at this as dark ages of pharmaceutical industry. I have no doubt, because in my mind, we have not only data that cannabis is grade A, we have data that if you combine cannabis with opioids, you're going to save 30% of lives lost. So if we have, say 50,000, probably closer to 100,000 deaths a year, just from opioid overdose. I'm not even talking about side effects and links of side effects to other complications. That's over, well, all of the meds combined. That's more than 250,000 people dying every year. If you just look at the opioid overdose, let's say it's 100,000, that means that 30,000 lives a year can be saved by introducing cannabis for the whole country. I mean, the data is there, and it's published in JAMA, in New England Journal of Medicine. I mean, we're talking about top journals that have been high-end quality studies publishing this data now for about 5 or 6 years consistently across every state that legalizes cannabis. In every single setting, cannabis is becoming an exit drug for opioid-induced.
So just to be clear, if someone's on opioids, you can start to wean them off by simultaneously introducing cannabis?
If you add cannabis, and percentages and exact dosing is not really clear here, but if you have somebody on opioid, if they're addicted and you start them on cannabis, you have a very high chance of having them off opioids within a short period of time. And the data is such that if you do that, 30% of mortality will be saved in this setting. And in my experience, upwards of 50% of patients will be off all opioids within 3 months when you do that.
That's incredible. I mean, if you think about the opioid crisis, right?
That's right. And there is actually, nobody's talking about it. There is not even close in terms of efficacy that anything's out there. Like for example, bupropion and Narcan and all those drugs. I mean, they're of course saving lives left and right. The problem is they're not an exit strategy often. The bupropion is, but it's a lot more complicated than people assume. And so the effective management, because it's not like, let's just stop the opioid. You got to address why a person went onto the opioid in the first place. If they have a chronic neuropathy or some other chronic pain syndrome, and you simply say, let's taper it off, what are you offering to a patient? The cannabis offers not just the exit drug, it offers the solution for pain simultaneously and basically completely safe, I would say, when you use it right.
So then it becomes the cost and access issue, right? That's where we might get into social justice and access to healthcare.
Justice, we get the fact that it's not covered, but you also have to look at this a little differently. At the same time, you have to look at the total burden to the society.
Yeah.
So the cost of patent opioids is, we're talking about $1,000 a month for many. Generics are way, way cheaper, but you're still looking at, say, $100 a month at minimum. And the cannabis cost per month can be in the $20, $30 if we have a national legalization and a bigger, so, right now it's probably closer to the same $100. But in terms of total cost in society to the future, you're also going to
save money. Yeah,
and you will transfer money from pharma to elsewhere. And I think that's partially here is the resistance, as everybody understands.
So there's a few things we want to talk about. Well, let's go more with you said there was obviously indications for chronic pain, for quality of life for cancer, and maybe some small studies showing it's helpful as a disease modulating agent for brain cancer. Some anxiety, depression, mood, neurovegetative symptoms. Anything else that are kind of big conditions that you want to highlight that you would focus on in your book?
Yeah, so anything that's related to neurodegenerative conditions, which is multiple sclerosis, Alzheimer's, Parkinson's, there's a very large categories of use. Primarily, we're talking about symptoms related to those conditions, like behavioral disturbances in Alzheimer's, motor symptoms, so the tremors and spasticity in Parkinson's disease, spasticity in multiple sclerosis. So all those conditions, cannabis can be very helpful for. There is a beginning of a new whole field of saying, could the cannabinoids, exogenous cannabinoids, could the extracts of cannabis plant in some way be used as part of the long-term strategy of curing neurodegenerative diseases? It's premature to say that we have a clarity, but if we have multiple signals that say it's going to be within a decade, I expect that it will be part of the standard treatment. And I'm talking about reversal. I'm not talking about symptom management here. So that's stay tuned. The data is all over the place. I'd say the most important areas for those conditions are sleep disturbances, kind of agitation, and motor symptoms. So those are the very big categories.
You're saying the research that's still out there, they're researching, say, like cannabidiol or like CBD, CBG, or what are they?
I'm not going to go there because this is a rabbit hole which we will not come out for the next 30 minutes if we get there.
Okay.
The long story short is, most of the cannabinoids, specifically, you mentioned CBD and CBG, have some strong neuroprotective characteristics. The problem with looking at those molecules and looking at something like, let's say, Alzheimer's disease is that the trials need to take potentially decades, because it's a very slowly progressing diseases. You have to look at them accordingly, and you have to apply protocols and study them accordingly. So it's going to be a long time. I'm actually not convinced that CBD and CBG are the most important molecules. I'm actually wondering if CBDV and some THC metabolites and even THC itself is going to be just as critical, if not more critical. So long story short, here's one word of wisdom for listeners. THC in young age in large amounts for the developing brain seems to be quite detrimental. There's no argument over that. That's one thing we know for a fact. So if you take a young brain, say somebody in their teens or early 20s, and they recreationally taking a lot of THC, they definitely doing themselves a harm. There's no discussion over it.
What's the mechanism for that, Misha, for that?
So we understand it actually reasonably well. The main mechanism is that what happens is your natural production of your internal cannabinoids, let's say anandamide, is something that's primarily done on demand. Let me give you an example. Let's say you are under a certain stress, and you are telling your body, we need to manage this stress. And critical part of management of that stress is your own THC. So your anandamide. And you will make it enough to control that particular stressful event. And that THC, from regulatory perspective, will help you to create further downstream signaling that will allow you to get over the stress healthy in a good way. Now imagine you suddenly take an exogenous molecule that's in inconceivably higher spike. Your endogenous production gets suppressed, physiology of the receptors is shifted, and the thinking is that leads to all kinds of downward effect, decreased brain development, potentially a loss of some cognitive functioning, potentially increased risk of schizophrenia, potentially increased risk of accidents, and all kinds of other issues. So there's no question that there is a negative impact. Now, adding CBD may be eliminating some of those impacts, and probably not maybe, but I'd say for sure, just not clear whether it eliminates everything, whether the safety level goes back to baseline. If you combine THC, what should the ratio be? Should it be 1-to-1 CBD to THC? Should you take 10-to-1 CBD? I mean, there's a lot of holes.
Do we have a general sense, because a lot of people are young at heart, right? Maybe taking high dose.
So let's go back to the other side. So you have young people, and then you have the older. It turns out that there actually some of that extra THC becomes brain protective. So here you have what we sometimes call a J curve. At one age, you have a negative impact. At another age, you have a positive impact on the same part of the body. I'm talking about just brain right now.
Okay.
So why that is not really clear, except for one thing. As we get older, our own endocannabinoid system and the cannabinoid tone, as Ethan likes to say, drops. So we make more molecules that break down anandamide. We have less receptors in the brain. We have less anandamide. So we can't generate as much anandamide. And that's actually a thinking partially why some of these neurocognitive conditions evolve in older age, almost always because you have this chronic disturbance in the endocannabinoid system that triggers in part. I'm sure there are tons of other triggers, but it's one of the triggers for evolving of Alzheimer's and Parkinson's.
Sounds like as we get older, we need more juice, essentially. We might need more juice.
All kinds of different juices.
What kind of juice? Pineapple juice, kiwi, whatever. And that's great. So what about other neuro conditions? Because I felt like what I've seen too is that people with migraines, people with mood issues, I've read before, and maybe you could corroborate this, is endocannabinoid deficiency could be causative, at least either triggering, causative, or perpetuating.
Well, that's what I'm saying. I think anything brain related, whether or any neurological issues or psychological issues, I think cannabinoids going to have a huge role in the future. I mentioned anxiety, but definitely for depression. I mean, there's a lot of people who use cannabinoids for depression in different combinations and mixes. PTSD. So I mentioned stress before for purpose. Turns out that our endocannabinoid system is #1 regulatory system of stress. Not the way we used to think that it's all like,
not adrenals, right?
No, adrenals are secondary. Yeah. Cannabinoids regulate how adrenals going to respond to stress.
Adrenals are in second place in the race. Is that
probably
what you're saying?
Say they're in third place. They're kind of, you just support them, but you don't,
What's the second?
The central mind body, right? So if you don't learn the primary regulatory, if you don't teach your body to self-regulate, the trying to support adrenals is like, putting a water on a major fire at the same time putting logs to that fire.
Just adding some more logs.
Exactly. So cannabis turns out to be critical there. So definitely anything chronically stress related, there's some definite use already. I'm not even talking about precise applications. That's going to come in the future when we have a lot more research out there. What else in terms of psychological, since you mentioned? Well, seizures, of course, everybody's talking about, especially since Sanjay Gupta's, I think that's number 6 weed series. He particularly talked about seizures and
seizures.
Well, I mean, we have a FDA approved drug for seizures, which is CBD, right? Epidiolex, which was approved in 2019. It's nothing but pure CBD. So we know that even FDA, even the medical community is already agreeing with some of this completely. But I see that this is going to explode. Other whole topic, which we could speak for hours, is dermatology. So it turns out
I'm sorry, what did
dermatology.
You say? Dermatology.
Turns out you can probably manage almost all dermatologic conditions with cannabinoids. Eczemas, any rashes, any allergies, any skin breakouts, infections of the skin like herpes infections, zoster, everything have cannabinoids. And we have a whole chapter on this. I don't want to go in there in great detail. Partially, that topic is so fascinating because obviously for those things, if the problem is localized, you can put cannabis topically right on the lesion. And it often is profoundly effective and low cost because you're not taking some massive doses internally You're applying small amounts right where it needs to go, which brings me to this whole concept of what I often say cannabis mantras. In palliative care, we have those whole bunch of mantras, like the hand that writes for the opioid that doesn't write for the bowel regimen should be cut off. Like we have those things in palliative way
Pretty harsh, but yeah, I guess that makes
fellows
sense.
that you have to do certain things, right? So
Yeah.
with cannabis, the mantras are start low, go slow, and then I edit this one and deliver where it needs to go. So it's actually most important in three, in my opinion, because we often think of cannabis more like smoke and take it orally, forgetting that there's all these other applications. I'm actually working now with a very cool group on trying to figure out how can you put cannabis in the eye, because for glaucoma, people smoke currently. That's not a really good intake because it doesn't last very long and can have a lot of side effect. And really the main reason, if you put something directly where it needs to go, amount of what you need to put there is way less. And so you're avoiding systemic toxicity, you're cutting the cost, you're making it logistically a lot easier, because often, and you're literally often removing any serious functioning problem, because one of the big practical reasons why a lot of people don't want to use cannabis, they're afraid of getting high. Let's put it this way. If you have pain and you smoke pot and you get high, people say, well, my pain is better, but I'm high. I don't want to be high. So what do I do here? Well, if you have a pain in your feet, for example, neuropathic pain, we'll try topical first. And I'd say that in some percent of people, it works, and it works really well. And they don't have to smoke or take anything orally. And suddenly you have a tool that is highly effective, relatively low cost, and zero central or kind of overall toxicity. I mean, you can have theoretical toxicity there, but it's way, way less likely to happen than when you take things orally or when you inhale them. So whole area out there.
Wow, that's amazing. Do you think the eye drops could potentially decrease intraocular pressure if people have glaucoma?
So it's actually not necessarily 100% clear. So it appears that THC will definitely decrease pressure. Problem is THC is not very water soluble. So you have to dissolve it into a substance that would be allowed to be put in the eye. So you can't put oil in the eye. You have to put aqueous solution. But acidic forms of THC and CBD, CBDA and THCA are more water soluble. So this is, I think, where it's going to go. You're going to try to put those molecules and try them out. But the old history is very unclear here. CBD actually could theoretically increase intraocular pressure. So nothing. If I learned one thing about cannabinoids, is there's nothing here simple. There's just nothing simple. It's a highly complex system with a lot of intricacies and details. This is why you should take the course. No, I'm just kidding. This
absolutely.
is why my point is that
sure.
My point brings me to the next really important topic, which I wanted to just touch upon, and that is we have to teach forget the current generation of physicians. This is just like lost quotes. No, it's just too complicated, unrealistic. The data is just coming out now. We're not going to teach. They're not going to learn it. We have to concentrate on the future generations, which is what I decided to take as sort of my sidekick, because I don't want to get involved in industry here.
So you have a course. You have a course.
No, we don't. I don't have a course. There's a lot of courses that are really good, and there's a lot of people who are much better educators than me. But I decided that what I do know how to do is how to get things done in academia. So we're actually trying to create a process in which we will create the set of minimal standards, and we'll take that minimal standards to the guarding body of all the medical schools in the country and actually in the world. And we're going to tell them, look, given what's going on, you must assure that every medical student graduating from medical school has some minimum knowledge of this topic.
Yeah.
Because right now, when they graduate, they only know the following: cannabis causes side effects. Here's the list of side effects. Here's what cannabis can interact with, and that's it. It cannot do any benefit. Nobody teaches in terms of clinical applications of benefits. They're only teaching pharmacology. about toxicity and metabolism. So currently the students, if they get excited by this topic, they have to find a mentor. There's very few mentors out there, or they're going to have to sort of wait until they're fully trained in their field, graduate, get their degree, start working, and then take one of those like fancy high-end courses.
It's a bit tilted against learning about the true applications. That this is a big disservice to, I guess, everyone, you know.
And not only that,
yeah.
there has been historically in the last 5 years a tremendous oppressive force from the AMA and from a guarding agency that makes CMEs. So that every doctor has to take X amount of CMEs per year in order to continue being licensed. And that actually applies to it's not just doctors, it's PAs, nurse practitioners, everybody. And so there's been tremendous pressure against not granting CMEs. So last year I was giving a talk at Andrew Weil's conference, and they were highly apologetic. Even Andy called me and said, look, sorry, we can't give you CME for your talk on cannabis. So Donald Abrams, who's a good friend of mine and a mentor, he got furious. He sent the letter to the head of CME at the University of Arizona saying, what the hell is going on? It's a highly evidenced presentation. I reviewed it myself. Like, what is this? How can you not grant CMEs? And the reason for that is very simple. It's a large medical industrial complex. They're afraid of this whole topic. They don't know how to handle it. There's no standards of education. There's no standard guidelines of anything here. So there's an oppression happening from not knowing, being ignorant. Maybe some pharma industry, I don't know, I don't care. But like, it seems like until we get past the crap and get to a point where minimum standard education exists, every medical students and every nursing student and whatever have some basic knowledge when they come out of the training.
It's a good idea. Mm-hmm.
How far from it are we? I don't know, but so I felt like let's try to do something in line with that, because if we achieve even the publication of such competencies out there in a very good journal, then it's a first moving step. So everything's going to move here very slowly. So if you're a patient and you're looking for cannabis expertise, good luck. You're going to need it.
Well, go see Dr. Kogan. That's definitely, you need to see Dr. Kogan.
Only one guy. And
yeah. Well, we can talk offline about the training programs, because I do think that would be really helpful for us to learn, and I think there's just need to be more people trained, out there.
There needs to be more people trained. There are hopefully going to be more and more academic programs, because part of the problem, there's a lot of great programs, Society of Cannabis Clinicians, Dustin Sulak has his own training. There's a lot of good people who doing, I think Bonnie Goldstein has a course, like there's a lot of really great courses. The problem is when they're not inside academia, or when they're run by the industry people, it's an automatic tension. Only a true enthusiast will take those courses, and that'll leave everybody else out, and they're going to be highly skeptical of joining these programs. And that's just a part of evolution. If you look at every other field that came before, the integrative medicine, for example, right? It's exactly the same. It took how many decades for integrative medicine silo organizations stay there, but now you have some kind of integrative medicine at every Ivy League, every medical school in this country, pretty much. So it's just a matter of time. It's a matter of continuous effort. It's a matter of creating standardization in the field. But the good news is that it's growing rapidly. Just because there's so much money in this, and there's so many new doctors coming out saying, and
there's people are demanding that that this is be more accessible. So let's say there's a patient out there, listeners out there, they want to try cannabis, medical cannabis, or CBD. How do they access this at this time? Is it different in different states?
So it depends on the state. Since we are in our tri-state area, let's talk about that first. So if you're in a district or in Maryland, and I'll talk to Virginia and separately, you go and you get your card within say 4 to 6 weeks. You have to have a doctor who will give you a recommendation for the card. And then they're set up dispensaries, and district has been doing this since it was approved in 2010, and dispensaries first, I believe, was in 2012. So it's been now 10 years. So they're quite experienced. There's a lot of different products. Prices gradually has been trickling down very slowly. We're still not anywhere near where we should be. Like we're still 2-3 times more expensive than Maine or California. So there's big discrepancies still, but nonetheless, it's going into the right direction. So Maryland is much newer. DC and Maryland have reciprocity. So if you're a Maryland resident, you can go and get your cannabis from district. If you're a Virginia resident, you can also get it from district, but you cannot get it from Maryland. And Maryland cannot get it from Virginia. So Virginia is the newest. It's been very recent that they added. Their dispensaries are still like just starting to have reasonable products. Right now, it's just the flower and maybe some gummies, but it's really not anywhere near where it should be. But you can get a license from Virginia and go get it from district. This
district,
is every single one of my patients do.
That's great. That's great. Great to know.
So, in Virginia, cards are in some ways even easier. The process there, the way they set it up is very simple. So, but your doctor has to have been approved to be a recommender of cannabis. We don't say prescriber, it's recommender.
Right. But when they go to the dispensary, who's actually recommending to them the ratios and the form and stuff like that?
That's where that's where the problems are. Yeah. So I recently was talking to a head of internal medicine at GW, and I said, look, do you want me to start training our residents in this topic? She said, no, we're doing it ourselves. And I'm like, you're doing it yourself? And I'm like, so what are you doing? Oh, we just teach them how to write the cards. And I'm like, oh my God, this is what's happening. They're just teaching them how to do the card. And then you have problems. And you have problems probably at least in 50% of cases, because the patients end up, in the best case scenario, they'll go to a dispensary that's much more medical, that has a staff that understands what they're going through, that they can ask them the right question, that they have enough knowledge to recommend the right ratio, right route, right dosing, right titration, all of those things. The reality is that, unfortunately, is highly mixed. The bud tenders are often clueless. We have a lot of people who are like 20-year-old kid who just finished.
Yeah, it's a roll of dice. I mean, it sounds
like it's a roll of a dice. Now Maryland is aggressive at trying to say that shouldn't be happening. Going forward, every dispensary will have to have a medical person on staff.
Okay.
Like pharmacist, nurse, physician, like somebody who is licensed, who can guide the dispenser.
That's good.
District is trying to design something. Virginia is, as always, in dark ages of the inquisitory time, wherever Virginia is. Sorry, not trying to pick on them. They're always behind
for cannabis. Yeah.
But anyway, so it's gradually going to move to the right place. But right now, the whole point, the way we wrote book, is for somebody to get the chapter that they need, let's say chronic pain, open it up and have a precise recommendation that they can take to the dispenser and say, give me this in this dose, and this is how I will take it. Now, of course, it's simplified. I still think that it's really hard to just use the book and go get something. You really still have to have a guide, because the reality is it's still more complicated than people think. And there's, especially if you have other medical problems, you're taking multiple medications, you can run in a lot of issues if you don't know what you're doing.
Time to take the courses that you recommend. I'll talk to you more about that offline, Misha. Well, thank you so much for coming on today. Everyone that's listening, please check out Dr. Kogan's book, new book, Medical Marijuana, Evidence-Based Guide to Health Benefits of Cannabis and CBD. It's a great book, and I think it's a great start. Like you said, it is more complicated than that for people with a lot of medical issues, but certainly even in the pandemic.
But even for those patients, there's a actual kind of a ground foundation what to do, and it's actually was written for. I had a lot of my colleagues say, "Hey, I got the book and I read it, and I now know what to tell to the patients." Like, so it's not in like an introductory level. It's pretty. Yeah. It's just the reality is when you start somebody on it, and if it's gonna become a tool, chances are that it's gonna get pretty sophisticated, and they're gonna be on 2 or 3 products potentially, and they're gonna be mixing and matching them. So there's a lot of learning, and there's a lot of like understanding and moving forward. So the book is putting you on that step to learn, but eventually you'll have to have more advanced knowledge.
I wouldn't expect, knowing you, Misha, anything you write to be introductory. It's very in depth and thorough. So yeah, that's great. Well, thank you, Misha, for coming on today. How can listeners learn more about you and work with you?
So so the gwcim.com, it's a clinical site. Those people who are on Medicare and Medicaid, they actually can try to get into my insurance-based practice. If you have a private insurance, I don't recommend it, because whole point is that leave my time open to those who are vulnerable, because I do try to balance my practice, both out of pocket, but also insurance based at university. So you can find me at gwdocs.com. I'm there, and you can try to get through to me that way. We only do telemedicine now for local states, I believe, because that's changing. I used to do telemedicine for the whole country, but I think that's shifting now.
Okay.
But in my practice, we still do that in out-of-pocket practice. And for the book, people can find it anywhere. I mean, it's a random house, so it's in Amazon everywhere. They have an Audible. Actually, I'm kind of proud, because the Audible was recorded by the same guy who did Life of Pi and Harry Potter.
Oh, nice.
So Vikas. So yeah, I think they did well with that. And then the soft cover is going to come out next year. I guess they're spreading them out by about a year and a half between the hard, because right now it's just a hardcover. So that's going to be much cheaper, because the hard.
Got it. I know you also have the Integrative Geriatrics book that you wrote, I think, earlier than that, right, with Dr. Weil?
So that's textbook. So
that's textbook. Okay.
Now I do have my next book is coming out hopefully within 6 to 12 months. Unfortunately, I'm going to compete with Mark's book. Exactly same topic, healthy aging.
Okay.
But hey, I didn't know he was doing this.
There's enough demand out there, I think, to learn,
Well, mine, I think, is going to be a little bit more towards complex geriatric conditions, rather than, I think, Mark's and Kara's book, Kara Fitzgerald, they're more like, how do you stay healthy, and what are I think mine's going to be a little more toward, you're already a bit older and you have multiple problems.
Complexities and stuff. Yeah. We'll look forward to that as well. All right. Well, thank you, Misha, for coming on today. And
thank you, Indian CIH. Thanks, guys.
Thank you.
It's wonderful to that we're local and that you're here, and then we collaborate on all kinds of things.
Yes, exactly. And thank you all for listening. And I hope you guys have a good day here the rest of the day. Thank you.
Thank you for taking the time to listen to us today. If you enjoyed this conversation, please take a moment to leave us a review. It helps our podcast to reach more listeners. Don't forget to subscribe so you don't miss our next episodes and conversations. And thank you so much again for being with us.